Hello, everyone. I am excited today to introduce you to Dr. Mary Constantino, an interventional radiologist.
Hey.
Let's get started with your day. Every time we do these What's Up Doc series, there's always a case that kind of stands out for the day that could be a lesson for everyone and something to open up our discussion for this afternoon.
Can I just start with like 5 minutes of things that I think?
Yes, please.
Okay.
You look like you have
So
a lot on your mind.
yeah, well, I see patients. I went into medicine because I love treating patients and hearing and talking to them. And it is sort of, the more you know about things, the more you realize how little we actually know about every disease state, right? So take anything, breast cancer. We think we know about breast cancer. Turns out there's 20 different kinds of breast cancer. So I'm in my 50s. So, I graduated from medical school in 2001. So now having these kind of decades behind me, you see the change of things that we took for 100% in 2001 and now how different things are. So in the vascular world, I look at where we are now and where we're going to be in 20, 30 years, and how can we try to expedite that for our patients now. The other thing I like to do is I look at our patients now and what Kim says. And by the way, thank you for having me and that wonderful introduction. I didn't know that you had some patients of mine, but I'm glad that they have good things to say. Um, I really look at it, get a lot of patients when they're really at the end. And I think, well, why are we having patients get to the end and then show up in front of me? How do we push them back so we're getting eyes on people here? What's
Yeah.
missing here? Now, it doesn't mean that we want to take all these people for procedures and surgeries, but as our surgeries have gotten more and more minimally invasive, why are we letting people go until they're sitting in front of me and I'm like, oh my gosh, I'm dealing with 40 years of disease that is 10 years too late to be in front of me. And now I've got to try to chip away safely at all this disease. The other thing I like to do is I like to turn to their family members and say, hey, 40-year-old son, 50-year-old son, this is you. So let's start that diet, exercise, walking. Let's prevent, right? To stay away from doctors and hospitals. That's how you stay healthy. So how do you do that? By the time your arteries are blocked, you're already at the end. But your family members can benefit from, what do we ask in primary care? Have your family members had heart attacks or strokes? Well, why are we not like, if Mr. Potts comes to me as a patient, why am I saying to him, do you have any children? By the way, you've got a lot of disease here. Pass that on. I mean, I have children. I'd like someone to tell me if I could alter there. Now I'm going to do that because who I am, but why we need to be really spreading this to the family.
Yeah.
And that's how, where is that sweet spot from I'm a healthy 30-year-old who can run a marathon to now I'm a person with a diabetic foot wound at 60 or 70, 80 years old. Where do we want to interface with people, not as primary care, but as proceduralist? Because you don't want to be too early, because then you're going to be doing unnecessary things, right? And every procedure could have a complication. So if I had to come up with that answer, I would say your single best thing that everybody in this country needs is a solid primary care doctor. The problem is there's a shortage. And what's been left is the generation that develops peripheral arterial disease, the same generation that develops heart disease and strokes. Those are the people I worry about, right? Who really need somebody who knows them, who can say, you know, I know Paula really well, and this is different. Or Paula, you've always been this healthy person who's been able to walk, and now you can't. Something's wrong here. But if you're just going to primary care or substitute primary care, they don't know you. And so your first line of defense is with a primary care doctor who knows you really well and can advocate and say, something's wrong here, and talk to you about diet and weight loss and exercise and doing all of those things to avoid getting on my table. Because once you see me, my goal is to intervene. So avoid seeing me, but don't avoid it too long. So I would say primary care, diet, exercise, all the things that people know how to do, not smoking. And I would say that we have a pretty good success rate in our clinic, because I do think that people feel that like we are here to help save this foot. Like I say people are going to die, but they're going to die with 2 feet on if it has anything to do with me. And too many people give up too early, that they just say, oh, whatever, you're a smoker. Yeah, you got arterial disease, whatever. Well, sorry, no option. And that's just not the case. If you're ever told no option, you need to seek a second opinion, and maybe even a third. I advise that with people who get diagnosed with cancer. If you get your lung cancer, it's very common to get second opinions. There's always different ways that people treat it. And vascular is no difference. The problem is that in people's communities, usually there's the doctors say, oh, well, we just refer to vascular surgery. Okay, well, who does that referral go to? It goes up into the sky and you get whoever you get. And if you show up in the hospital through the ER with an infected diabetic foot wound, you get whoever happens to be on call that night. That person may or may not know how to do endovascular work. They may be like, I don't want to be bothered. I don't like this work and I don't want to be bothered with it. Sorry, no option. And we see that a lot. We actually see that quite a bit. So unfortunately, we are in the era of being your own advocate in this way, just as you would like really try to understand your disease. There's some great studies out there. Abbott is a device company. They did a beautiful study. It took them 3 years to do, where they said, it's so strange. PAD patients have no understanding of their disease. And I blame this primarily on the doctors who don't spend time saying to you, here's where your blockage is in a way that you can understand. They're saying, oh, you have, a 29% stenosis with tandem lesions and intimal thickening and partial occlusion of your TPT. Like, how does that help you? Right. So what we do is we have drawings. Everybody, when our ultrasound, we draw it out and I can show it to a patient and say, this is where your blockage is. In fact, I probably have a drawing right around here somewhere. But okay, I have one right here. Let me make sure that we don't have the patient's name on here. But like, this is the kind of drawing that we'll give. Okay, so we see the patient's foot, we see her leg, we see her blockage. And this is the knee, and I literally put my hand on them and their thigh, and I say, you have a blockage right here on your thigh. That's that. And now this is open. Here's your knee, and you have 3 vessels below the leg, and you have 1 blocked, but the other 2 are good. Here's your wound, and this is your blood flow to the wound. And you get a picture like this. So people
And
can understand.
I want to
What's
point
that?
out I want to point out why you have that up. Because I think this is so brilliant. We should have something more like this. Maybe you can loan one to us. But look behind. So if you get an ulcer on your heel, it's that posterior tibial artery that
Yes.
might be the blame. That might be the one that might be compromised. And then
Right.
can you show
Yep.
and then the one on the front. So if you get one on your big toe, where the blockage? If you have one, let's say on your big toe, we get a lot of people that have their big toes that end
Good.
up wound.
So we're going to take this to another level right now.
Oh, I love
Okay.
that. Okay.
So one thing that we do in our clinic is called pedal acceleration time. Have you heard of that, Kim, or anybody?
I know
Jill
Jill
Somerset?
Somerset very well.
Yeah.
She was
Yeah.
our diagnostic genius of the year for 2024 in the Global PAD Impact
Yeah.
Award.
I mean, this woman has changed vascular, and she has changed the way we approach vascular wounds single-handedly. She's an ultrasound tech. And about probably now 7 years ago, she was watching a procedure and saw a doctor put a wire into a foot, right? Because we can put wires all the way around the foot. I mean, we can go all the way down to the tiny little vessels. So a lot of times people will only treat here or sometimes here, and we can put wires and balloons and whatnot all the way into these arteries in the foot. And so she watched somebody put a wire, and she said, I wonder how they measure that. And she drove 3 hours back to her hospital, put the ultrasound probe on her foot and said, oh, wait, this is crazy. We can actually see the blood vessels in the foot and we can define them. And so she really started putting them in a classification. And then came the concept of, if you have a wound on your toe, what is the most important vessel? Okay, so this is like a hand, same thing in the hand. And now we've done this for the hand too. let's say the wound is here. This should be on the radial side. This is the radial artery. This is the ulnar artery. Ulnar, radial. If you have a wound here or here, that's on the radial side of the hand. The hand has a loop that goes around like this. The ulnar comes up and is supposed to do this. That's the ulnar nerve distribution and considered the ulnar artery distribution. So in the foot, we talk about angiosomes. This is the radial angiosome and this is the ulnar angiosome. So people would say, if I have a wound here or here, I need to treat this artery. Well, what being able to look at the foot with the ultrasound, you can put the probe right where that wound is, and you can follow the path of blood all the way back, and it may be coming from the ulnar artery. So the way this matters is, let's say you have this, and let's say you have a wound on the heel. This artery here, the middle one, is called the perineal artery. This little branch right there is called the posterior communicating and the anterior communicating. Sometimes this perineal comes down. This anterior communicating is really, really big. It goes through this course and actually supplies the lateral plantar that supplies the wound. So that tells me, if it goes like this, that really I need to treat that artery or that artery, and I don't need to go intervene on that. The beautiful part about this has all been played out in the literature. There's multiple published studied in the vascular surgery journals. It's called pedal acceleration time. The problem is, the reason not everybody uses it is you have to hire an ultrasound tech to know how to do this. So most doctors who have heard about this want to do it. And Jill has worked tirelessly to train people over 7 or 8 years. She works in my lab. So when it comes to diabetic foot wounds, the question is, what flow is it? There's 4 grades of flow. Do you have class 1 and class 2, or do you have class 3 and 4? 3 and 4 need a procedure, 1 and 2 do not. So if you're going to a place that has pedal acceleration time, they can put a probe on your foot and say, I have class 1 or 2, I'm good. I have class 3 or 4, I need an intervention. So when we look at like our clinic, we actually looked over the last 6 months, we had about 150 new wounds, okay, 150 people. 105 of those had class 1 or class 2 flow, which means they don't need any procedures. So I've right there saved the healthcare system a ton of money. I've saved a patient from having to go through a procedure. I've saved the unknown of, oh, we need to do a diagnostic angiogram and see more. I do about 3 diagnostic angiograms a year. I don't think we need to be doing a lot of diagnostic angiograms because we have ultrasound. In my facility, we have ultrasound that can be really, really good. The reason I can do that is because I can control my who I hire, right? So I don't want to say that other people are well-meaning or don't want to have this, but if I work in a hospital, I can't hire an ultrasound tech to do this work. And in fact, all of this was started in the hospital, but then the hospital administration started to put handcuffs on them, and so they couldn't get the work done. And that's how it's moved into the outpatient space. So I'm not trying to say that other people don't know about this or use it, but sometimes it's a logistical thing. But that is the single most important piece of information, to not only classify your wound, but also to not do procedures that you don't need them on. And then if you do a procedure, what the target vessel is really important. And we can know that with ultrasound in a way you can't know that with angio, can't know with CT. So when Abbott looked at this information, what people knew or didn't know about the arterial disease, they really found that people couldn't tell you what they had. And I think this comes from the heart world. If you have a heart attack and they do the dye study, the angiogram, they put in a stent and they tell a patient, your heart is good as new. And so what the crowd of that geographic demographic, the people with heart disease or the ones with arterial disease, they expect that they go through a procedure and they're good as new. And that is not the case in legs. I call arterial disease of the legs like cancer of the legs, right? And I know I keep on saying that C word, but we really need to understand this is an ongoing thing, right? Once you have it, it's ongoing, and it takes love and attention and care. And people come into my office and I say, I'm going to work really, really hard to open up these arteries. I'm going to fight for this leg, but it's what you do on the outside that's going to matter. And it's the walking to build new blood vessels. And my goal is to be successful here and then never have to put you back on this table. And that doesn't happen because we're in a team. My patients and I, we're a team. And we get a lot of people to stop smoking because I'm looking at them being like, okay, if you're going to make me go through this challenging case, you need to be very compliant on the outside. And that's how we're going to have the win for you. But I also will spend the time to tell them, and all arteries are different. And sometimes we have really heavy smokers and their arteries are perfect. And we have people who have lived the healthiest, best lives in the world and their arteries are terrible. And this is where I think genetics is such a big part of it. So so I'm not in the blame game. I'm in the like, all right, you're in front of me and we've got this issue. What are we going to do? What are we going to do about it together? And I promise I'm by their side. And that's how we have success with teaming together.
And it's interesting that you said with this pedal acceleration time, this new measurement that you can do with, with Jill Somerset creating this new device, new way of measuring the flow in the foot, especially when a person has wounds. But because it's interesting to me that you said that if they have a non-healing wound, doesn't mean that they need blood flow. And it's interesting because if you look at the criteria for doing a procedure, it's, well, you have a non-healing wound, do a procedure. But you're saying, hey, I would think the hospitals would be all over this because they're literally like, no procedures, just walk, then just come back. When you can't walk anymore, we're just going to amputate.
It's so weird what they do and what they don't do. And it makes no sense. So you're right. Like if we had to give one message to somebody, one message would be, if you have a wound, you need an angiogram. You need somebody to evaluate your arteries. Because we're coming from a place where at one point, 50% of people with amputations never even had an angiogram. And we don't want that. Right. So again, I'll pick on you, Mr. Potts. If I'm, because I don't know Grammy's last name. But so if I am going to take Mr. Potts' foot wound and I'm going to give him the choice of nobody looks at his arteries or we get an angiogram, I want you to have an angiogram 100% of the time with an intervention. 100% of the time. But if I can take that the next level and say, okay, now everybody with a wound has access to the best vascular care you can get. Now we can start to say, I could do, and I will do, and I'm able to do an angiogram onto you, but should I? And only with objective measurement, right? Not my opinion, not, oh, you look fine, or, oh, let's go on, or, oh, I've seen this before. But we have a number, we have an objective number with an ultrasound that says, the blood flow to that wound is 135 milliseconds. I can tell you, based on the data, that 95% of those are going to heal in time. And that's played out. So I kind of am flipping it on its head, but it's because we came from such a bad place where so many people have a wound that got blown off in the vascular world. And this is why I say only in the hands of pedal acceleration time should someone say, okay, now I don't need an angiogram. Now I don't need a CTA. Short of that, diagnostic angiograms are where it's at. So it is going to be a little different than what you're hearing because I have this capability to take it to the next level, but I'm one woman in one little place. So it's not going to be, it's out there in a couple places. The other thing, so the wounds that have good flow are pressure wounds, diabetic pressure wounds. Those are often on the ball of the foot here, where it's just the pressure of a foot or a deformed foot. It's sort of like a pressure, like a bed sore. It's like a bed sore on the foot. It's not because lack of flow.
We have a patient's daughter that is asking about. Her mom is actually in the hospital right now getting an IND incision and drainage of a wound, little pus bubble right there on her toes. They did an ultrasound on her leg and her foot, and they said that it's unremarkable, meaning circulation's fine. But okay, see, you're shaking your head. So the orthopedic surgeon says it's not a vascular problem, and he wants to cut off 2 more toes because of osteomyelitis and some pus that are around the bone. And thankfully, we got a hold of an interventional cardiologist who said, I'm not 100% on this. I'm not sure that I can actually just trust this ultrasound. Something still bothers me because, just as you said, a lot of those diabetic ulcers are literally in the pad of the foot.
Yeah,
And she already lost the pinky toe. And
yeah.
then it spread to the other toe. And in the pinky toe, the amputation point did not heal. The incision did not heal. So he's going in on Thursday to do an angiogram to check that pedal arch because he has a feeling that there might be a little restriction. The orthopedic surgeon says, no, he doesn't believe there is restriction. The arteries, he thinks the only restriction is the pus bubbles that are there in the around with the infection. I don't know
Yeah,
what your thoughts might be. I see you shaking your
100%.
head.
I'm on the side of the cardiologist. So this drives me crazy. And thank God you guys exist and this daughter reached out to you. Ultrasounds are, everybody does different levels of ultrasound, right? And so I love this cardiologist knows what the outcome of this could be and is saying, nope, not letting this happen because, oh, it's basically normal, not when you have several wounds, an abscess, and osteomyelitis. Now, it may be that, like, I'll talk to the podiatrist and they'll say, oh, there's lots of bleeding, right? I'm debriding and there's blood everywhere. I still would do the diagnostic angiogram. Like 100%, if I'm that daughter and like nobody's cutting anything off until we get that diagnostic angiogram, because you want to maximize that blood flow before you do any amputation, because the risk is that you amputate those toes and that doesn't heal. And then you end up with a transmetatarsal amputation, which is right across the foot. So all the toes come off. Now we're kind of sick world, we're okay with a transmetatarsal amputation because it can heal and the patient can still walk normally. Right. And so, but after a transmetatarsal amputation, then you go to a below the knee amputation. So what can happen to these guys and gals is that you cut, doesn't heal, you got to cut more, doesn't heal, you got to cut more. One amazing thing about pedal acceleration time, and one way we use it with all of our surrounding podiatrists, is we have patients who need surgery. And we've trained our doctors to say, I want to do a bunionectomy, right? This patient needs a bunionectomy. They have no wounds. They're having an elective foot surgery, but they're uncontrolled diabetics. They were heavy smokers, and I don't feel the pulse. You put that probe on there and they could have class 4 flow. One thing we know now that we can measure flow to the foot, and it's very hard to tell by physical exam whether you have class 1, 2, 3, or 4. And we've got numerous cases of this where the feet look just like mine, just plain old normal feet, and have class 4 flow. Now, you don't know that until the podiatrist goes and does the surgery and then has a non-healing wound from a bunionectomy. Now that gets infected, and now you're in a problem, right? Now you're looking at transvestral amputation, and then you'd ask any patient, would you rather have a bunionectomy? You'd rather have your bunions than have that situation. So one way that we use PAT around here a lot is we measure people's blood flow prior to surgery. It has reassured the podiatrist, I'm not going to get into a situation that's going to end up with a poor healing. Now, if you can feel a pulse, you're good. Feeling a palpable pulse, you're going to have class 1 flow. Short of that, you don't really know. Even if you put the Doppler on and hear the biphasic, you don't really know. So where is the role for PAT in podiatrist offices before they amputate? So this is some of the prevention stuff that I really like. And we have some great cases of people I really think we prevented a bad outcome. But absolutely in the hospital with a diabetic foot wound, angiogram 100% of the time. Unless Jill Somerset is there to do a PAT. Or I'm
So
there
what
to
does
see
this
the
mean?
images, but
Okay, so we're the real takeaway for patients is always, always, always get that angiogram. Just in case, because there are limitations to what a general ultrasound can uncover or reveal.
100%. And in most people with wounds, they have calcified tibial vessels. So the tibial vessels go from the knee to the ankle, and there's three of them. And if they're, and it's hard for patients because you can't see the report. I can read a report and know by the language how much someone's paying attention. Usually, right now, nobody's paying detailed attention to these arterial ultrasounds, especially in a hospital. They're just like, oh, it's patent, the flow is good. I just had a patient who went to vascular surgery and they recommended amputation. And this patient had his other leg amputated last April. This is the kind of patient we'll see. One leg developed a wound on the other leg. The hospital folks took him, did an angiogram. The angiogram's beautiful. You see a blue wound blush, a gorgeous arch. I mean, it's gorgeous. There's not a drop of arterial disease. Because the wound was non-healing, podiatrist sent him back to vascular surgery. Vascular surgery said nothing to do, recommend another BKA. So now you take a guy who lost his one leg last April, and now he's going to lose his other leg. He has not yet been able to walk on his prosthetic made for his first leg because he has this other wound. He has swelling in his legs, really bad swelling. All he needs is compression. And nobody bothered to compress him because the surgeon has said, well, he doesn't really, I don't know, there's not a whole lot to do. And so he's sitting in a wheelchair with one leg already cut off, with another wound, getting no wound care, and nobody's compressing him. So I went back, I reviewed the images, and I called the podiatrist and I was like, and I actually sent him pictures and I said, this angio is beautiful. He's got not a drop of arterial disease. There's absolutely no reason this guy can't be compressed and healed. And I'm holding that podiatrist accountable, but it's just laziness. If you want to be honest, I feel like that was just all laziness and bad information. So that once the podiatrist knew that, like, I was on this, and by the way, I don't get paid to do any of this, right? Like, it's not like this is out of, and I'm only mentioning that because this is the kind of person you need to do who needs to be in this critical limb space is the kind of person who's going to say this, something's not right here. And not just say, we'll just amputate the other leg. And now you have a double. And I actually had a discussion with a patient's insurance company and was like, everything about this is wrong. This patient needs home health and compression. That's it. And someone who cares enough to get this guy what he needs. So I get real livid about this stuff because they show that the mortality after amputations is really high. And yeah. I'm controlling myself, but I get so angry at the lack of attention that is paid. And it's the systems. It's not the individual person. It's the systems make this very complicated. But when we're not feeling compelled to do these things, it's when we need to get out of the critical limb vascular work, right? Like we shouldn't be doing this work. Like we don't become pilots if you're not willing to fly the airplane. You can't get all the way there and then say, I don't feel like doing this anymore. I'll go sleep in the back.
And that's why, today the Society for Vascular Surgery launched this great new website called Your Vascular Health for patients, including a doctor finder, which includes only vascular surgeons, of course. But my issue is that if you look at the list of vascular surgeons, I could point out who is a critical limb doctor and who is not. Yet every single one of the doctors will tell you that they do treat critical limb ischemia, but they're not CLI operators as per the CLI Global Society and what it means for someone to use advanced tools and techniques to save a limb. And I think that we all need to go above and beyond. And I think that the doctors need, every doctor, whether it's a vascular surgeon, whether it's interventional radiology, whether it's interventional cardiology, needs to, take a step back and own up to what is your skill set. Are you a general PAD specialist, or are you a general vascular specialist, or are you a CLI operator? Because CLI operators, that is all they do is CLI. And they fight every single day, exhausting all efforts, putting their life on the line to save limb every single day. They're not just going to be in and out in 45 minutes or an hour. Most of these doctors will spend up to, 3 hours, sometimes 5 hours for some, patients with lots of comorbidities, such as chronic kidney disease or, late stage diabetes, type 1 diabetics. They may not be able to be in a procedure for 3 to 5 hours, but these doctors will responsibly spend the time needed to open up these vessels and get just that much more blood flow to get a patient on their feet. Those are CLI operators. Those are the ones I tell every patient, when you're choosing a doctor for PAD, you need to think well ahead. You need to think of what if. Not that you'll ever need your pedal loop, the artery loop in your foot, the pedal plantar loop in your foot. Not that you'll need that ever opened up. Wouldn't you want a doctor that has the ability and willingness, if medically appropriate for you, to have that skill set? We have so many doctors that still will only treat to the knee. They turn on the faucet. They don't make sure the plumbing below can handle that extra flow being turned on. And then the patient says, "Doc, I'm still feeling pain. I'm still getting leg cramps." And they say, "Oh, you just walk, walk, walk. When you can't walk anymore, we'll amputate." And literally, I'm thinking of a very specific patient right now in Michigan that this has happened to. And so it's very important for these doctors to step back and recognize. And I even think that it would be great for societies to come together, don't you think? Get SIR, get, SCI, get SVS together for all practices and say, let's classify each doctor based on skill set.
Wait, Kim is alluding to, and by the way, where this is changing is through people like you. You're the people on this phone and Kim McNichols, like what you've done. And this didn't exist prior, right? And I've seen this in the other thing I do a lot of uterine fibroid treatment. What really changed the world in uterine fibroid treatment is the patients talking. They're usually 30, 40, 50-year-old women. And once the internet came alive, those women came alive and they became really strong advocates for themselves. The PAD world is a little bit different. There's a different generation of folks. And so it's really like this kind of thing is what I believe is going to move the needle. The political environment for doctors, I'll touch on, and I kind of feel not embarrassed because I didn't do this, but this is just where we are, where what Kim's talking about, the Society of Vascular Surgery, Society of Interventional Radiology, Society of Interventional Cardiology. There's 3 groups of people, 3 types of trained doctors that do this kind of work. Every group says, we do it better than they do. We do it better than they do. So for example, Society of Vascular Surgery has a list, but they only include vascular surgeons because they say, well, vascular surgeons really, we do it best. And I'm an interventional radiologist. Our whole business is catheter, minimally invasive. I don't do open surgery. So to Kim's point, I do the catheter stuff really well, and I don't do the open stuff. But I know people who do the open stuff really well, and I know my lane, and I stay really in my lane. This group of physicians, and I'm going to speak generally, it's a very ego-driven group. And that rings through in all levels. And I mean, I love the colleagues I work with, right? So I'm talking about my people now. So there's a lot of like internal conflict. And because of that, it makes it a lot harder for patients because Kim is exactly right. What we need who's doing critical limb. And by the way, it's okay not to do critical limb. We need people who are going to do the aortic bypasses. We need the open endovascular. We need all of it. But there's been this sort of what's cool to do. And, everybody says, I do this. Well, do you do a lot of it or a little bit of it? And everybody's got to start somewhere. But this is what the critical limb doctors say. And on everybody's website, it'll say they do critical limb, they do all this. But I would say that if you're ever told there's nothing to do, that's time to get a second opinion. What happens to me is patients are told there's nothing to do. They come in, we say, I feel like there's a lot to do here. And they don't trust that. They're like, well, this is so different. It is so different from what I heard from that hospital guy. And I'm always like, well, I get second opinion, get as many opinions as you want to get. But I do think that if anybody hears there's nothing to do, you need to get a second opinion. In those patients who truly are no option, no vascular option. Okay. So I've gone in, I've done every piece of work that I could do. I've called every single one of my critical limb friends and said, is there anything that you think that I should do next? And everyone says, literally, there's nothing. It's what we call an orphan foot, meaning the blood vessels, and it's usually in diabetics, the blood vessels. So again, this is the foot, all the little small vessels kind of peter out. So I imagine like a branch and tree, leaves on the branch, the leaves just kind of go away. And so you have the trunks and they get smaller and smaller and smaller, but there's no leaves that fill the tree. That means no amount of increasing blood flow to that foot is going to get more blood to your toes, because remember, all the little leaves are gone. That's an orphan foot. In that scenario, there are actually two options these days. There's something called a deep vein arterialization. It's a complicated procedure, but it's there. This was Kim, the meeting I was talking about with AMP that I went to. We had a full day on DVA, and there's some really exceptional DVA operators. It's in development. I'd say it's been around for probably 3 to 4 years. There's going to be 1 to 2 people in every state, possibly. A lot of states probably won't have anybody who does DVA. So even in the no option orphan foot, DVA, deep vein arterialization. The other thing is a spinal cord stimulator. So the spinal stimulator has just been approved for anybody with diabetic peripheral neuropathy. That happened a year ago. So now patients with painful diabetic peripheral neuropathy can get a spinal cord stimulator. The beautiful part about this is there is a trial that you can do. So in the old days, you used to go in and we would put in the spinal stimulator and you'd say, yes, it worked, or no, it didn't. And that was 50-50. And if it didn't work, then you'd have to go through the process of removing it. Now we put in a little trial, we put a little lead into the back, and we see over 3 to 4 days, does your pain improve or not? If it does, well, either way, the leads come out. If your pain improves, about 80% of people will have at least a 50% improvement in pain. They go on to have the implantable device. If it doesn't, you don't go on to have the implantable device. So many people with diabetic neuropathy are told nothing to do. It's just your diabetic neuropathy. Sorry, nothing to do. Gabapentin, which works in like 30% of people, and it makes people feel terrible sometimes. Some people do get some relief, and that's great, but there's a lot of people who don't. And we all see on TV the little exercise machines. Diabetic peripheral neuropathy is a real problem. What's interesting is because we can measure blood flow to the foot, we see, and this is very, very, very early preliminary, very, very early, but we're seeing that the blood flow to the foot increases when you put these spinal cord stimulators in. So yet again, we have another no option patient who really potentially has 2 options. Now, a patient may or may not want to do that, but it's not no option.
That's right. I always, 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 I say, you've got to get a second opinion, no matter what. Even the patient today, orthopedic surgeon, I got on the phone to get another podiatrist, because a foot and ankle specialist who's orthopedic is different still than the training for an actual podiatrist. And so it's really good to get different opinions from different practices that might have different philosophies and different training, different tools, different techniques. And we have a question coming in that Joshua has obtained from Dennis on our YouTube channel. He asks, what is your opinion of board certified chiropractic radiologists? Are they real radiologists? I'd never heard of that.
Well, we have in Pacific Northwest, we have a very liberal licensing where PAs, what in large parts of the country they call mid-level providers, are licensed to practice. And yes, board certified chiropractic radiologists. So are they real radiologists? They're not MD radiologists. So one thing to look at is, are you going to an MD? Or you're not going to an MD. Now, I'm a believer that everybody has a role. Okay. I'm a no judgment zone. Like, I have a PA who works for me. I am a board certified radiologist who does interventional work. So that is all those years of training. And that's an MD board certified radiologist. Now, what has happened is different fields, like chiropractors have said, we're back people. Why can't we read x-rays of the back? We're just going to create our ability to do this. And it's not necessarily all bad. Chiropractors know what they're looking for, but are they board certified radiologists like me? No. Now, I have worked in a place with a chiropractic radiologist, and I thought he was really good. He stayed really in his lane. Remember, it's all about staying really in your lane. Medicine is full of people who want to tell patients that they do everything. And I am really clear on things I do and really clear on things I don't do. So that is a hedge of an answer where if you're going and there's some chiropractic question and some chiropractic radiologist is interpreting that image, then depending on who they are, they may be actually pretty decent of doing that. Where I worry about these things, the vast majority of imaging, I don't want to say vast majority, there's a significant amount of imaging that's never read by a radiologist. So about 15 years ago, maybe, ultrasound machines started popping up in gynecology offices. MRIs started being used in orthopedic centers. Okay, so now who's interpreting these images? There's a shortage of radiologists. And so now you have everybody kind of interpreting their own images without the formal training. It's just something to look for.
Good question. Good answer. Okay, I want to open it up. I know we have a few questions here in the group. If you have a question for Dr. Constantino, go ahead and unmute and we'll get to you one by one. Looks like we might have a question from Alan. Do you have a question? Okay,
Yes,
go
I
ahead.
do. Yes, I do. I couldn't find the raised hand thing for questions. I don't see it there.
Well, thank goodness I saw you.
Yes, thank you. Doctor, I gotta be honest, I feel silly asking you this question or these questions because your expertise level is just off the charts. Oh, I really appreciate it.
There's no such thing as a silly question, truly. A lot of times I miss the mark and talk too much about that stuff. So no such thing.
Thank you. Okay. So I've had PAD since February, and just a few weeks ago, I got diagnosed with peripheral neuropathy. And I'm sort of just starting to do research on peripheral neuropathy. And this morning, ChatGPT told me that I should get some alpha lipoic acid. It says it's an antioxidant that may help relieve symptoms of peripheral neuropathy. And it told me to get acetyl L-carnitine. It said it may help regenerate nerve cells and improve nerve function. Are you familiar with those products at all?
No, I mean, I've read, like I hear about them.
Yeah.
B12 is another one.
I was just going to say the B vitamins, because even podiatrists will actually prescribe them as part of their, and they even have them where they're not combined. I was told by one podiatrist that he makes sure, and he says, I do the B6, the B12 separate, and make sure there's a full supplement for each one. When he prescribes, he says that's the only way it'll work.
So I'm taking a B complex pill and I take a B12 pill. Should I also be taking a B6 pill?
Do you want to answer that?
That would be something that you should ask your primary care, your family doctor, to make sure that it is in fact right for you. If you do have a podiatrist, they're the ones that I typically hear this from because they deal with people who have peripheral neuropathy, especially in the feet, and that is part of their protocol that they offer to their patients. So it's definitely something that I would ask them. I don't know what the care is there in terms of in Canada for getting a referral to a dietitian or a nutritionist, but that is usually the person that can really help you break things down and help make sure that there aren't any. And also a pharmacist is a fantastic one to make sure there aren't any contraindications.
I've learned to talk to the pharmacist before you talk to a doctor.
They're a wealth of knowledge.
Yeah, they are. And they see so many patients with their medications. I get real hesitant to recommend medications. I mean, there's side effects to everything in terms of depending on your person, even I think it's, and I don't medically manage diabetic neuropathy, right? So I do procedures. But from what I see at the podiatry, there are certain ones who do a lot of good care for patients by recommending some of these supplements. And it's vitamin B12 that I see the most of. And I would definitely look for a podiatrist who can give you medical management advice on that. But like I said, the spinal cord stimulators are FDA approved. That's the United States thing. So not everybody needs one. If it's tolerable diabetic neuropathy, you don't need one. But if it's like, I can't sleep at night, my life is miserable, that's another consideration.
My neuropathy at this point, I would consider to be tolerable.
That's great.
Yeah.
That's great. And yeah, and neuropathy just means dead nerves. And so anybody who has foot pain, we always do that pedal flow. We always look at the flow because there's not really a way to say, are your nerves dead because of the diabetes, or your nerves dead because you don't have blood flow to them? One thing that can clue you in is something called rest pain, which means when you elevate your feet on the bed, they hurt and they feel better when they dangle. If that's the case, then that is a high risk of having arterial compromise.
Having arterial compromise?
Of arterial disease. So when your feet are better hanging down, you put them on the bed and they hurt. They wake you up at night and hurt on the bed. And you wake up and you dangle your feet and they feel better.
Yeah.
That to me says arterial disease.
Okay.
And we do have a lot of patients that are over in Canada, and also we have quite a few in Europe that end up with a diagnosis for peripheral neuropathy, but it's only because the doctors do not treat the arteries below the knee and into the foot. So it still may be an arterial problem, and they'll just chalk it up to being peripheral neuropathy because they just don't believe in offering any options to opening those smaller vessels with wires and balloons. But they do have
worse than a patient who has had 8 years of what is rest pain and they are diabetic. So they've just been told you have diabetic neuropathy. And they don't. They have rest pain, which is end-stage arterial disease. But they get blown off because they're diabetic. So it's just, oh, you have diabetic neuropathy.
Yep. And we hear that all the time. We see it all the time. And they do have spinal cord stimulators at some facilities in Canada, SCS. So you might want to just double check. And it never hurts to get a consult and find out if it is something that's right for you, just in case that you might need it in the future.
Yeah. Yeah. I'll talk to next time I see my vascular surgeon, I'll talk to him about that.
Thank you, Alan. When Alan participated in our Food for Thought, Patty's Plate, Fruity Friday event a couple weeks ago and learned how to cook artichokes.
Yes, I did.
Cool.
You continuing to eat healthy, Alan?
Yeah.
I generally, yes.
Just don't put a bunch of mayonnaise on them or butter.
No, I don't. I have no mayonnaise in my house anymore, and I have no butter in my home. I don't use it.
You know what I do for them now is I do an egg with extra virgin, high polyphenol olive oil with a little Dijon mustard, and then I put it in a little, mixer, and it makes a nice creamy, healthier sauce.
Nice.
Yeah.
Nice.
But what we did one, we actually made one with yogurt. We did it with non-dairy, like cashew or almond milk or coconut milk yogurt. And we doctored it up for our presentation. So that was really fun.
Nice. I made a sauce 2 days ago. It was a blend of parsley, cilantro, garlic, and that good extra virgin olive oil. And I made it to put into a soup, but you can use this mix on chicken or pork or whatever you want, whatever you're eating. So
good. See, it's like Diaspora. We're just kind of, spreading, right? With healthy things. Marcia has a question. Go ahead and unmute and ask Dr. Constantino your question.
Hello, and thank you for joining us. You're very interesting and sound like you really know what you're talking about. My question is, I don't want this to come across as degrading or anything. It's just purely to educate me. So a lot of these doctors, pad doctors, do the uterine fibroids. And my question is, Like my doctor is an interventional cardiologist. If he was doing, to me, female surgery, I would think he's not focusing on what I need. And so I'm curious as to, since you do it, why that is, and like I want a specialist who really knows my legs. So if somebody's working up, you know, at the uterus, I'm not interested, and I'm probably wrong.
It's a really good, it's because it's because of the interventional radiology field. Okay. So when interventional radiology is we push catheters. So what we do is any image guided, anything that requires a catheter to get there through a vessel. The first angioplasties were done by interventional radiologists in 1964, Charlie Dotter. And that's the Dotter Institute here in Oregon, which is how I ended up in Portland. So the history of my field is we have an artery. What can we do to treat something on the other end of it? Okay, so we drive boats down rivers. And that river may be in Germany, it may be in Korea, it may be in the United States. We just drive boats down rivers. That's what we do. Drive boats down rivers. We don't fly airplanes. We don't parachute. And so when you start driving the boat down the river, you get into the arteries, you can go to the brain, you can go to the heart, you can go down and go into the uterus, you can go to the liver. All you have to do is twist your little catheter and you can go anywhere in the body really quickly. Then what do you do when you get there? If it's a tumor, we can push in these particles and stop the blood flow to the tumor. If it's a cancer, we can push in these particles. Sometimes they have radioactivity on the end of them, and it, goes in there and does some radioactive treatment of the cancer. If it's a trauma, a gunshot wound, we can put in a little coil through the catheter. So it's kind of like we're sitting in this river, and we can fish for salmon, we can fish for this, we can fish for that, but we're just sitting on our boat. That's my field, interventional radiology. All right. So what differentiates, so I am biased because I do my field. I told you everybody says we're the best. I would say, Kim probably can attest to sometimes the conflict. I would say that I am on the way more accepting side of, hey, let's all do this together. Because I also think it's really confusing for patients when you have me tell you, oh, vascular surgeons aren't as good as this as I am. Vascular surgery comes from the vessel standpoint, right? So it's just like you said, their history is they cut to open and they do surgical bypass. They're not boat drivers down rivers. They're helicopter people. But as things got more and more minimally invasive, and this was in my lifetime during my fellowship years, 2006, 2007, they turned around and they said, guess what? There's all this new technology now to be going through arteries. We don't need to cut open and clamp and do surgical bypasses. We can go through arteries. Who's going through arteries? Wait, they're going through arteries. We want to go through arteries too. So then the vascular surgeons, and this is 2000, like I said, 5-ish, had to say, where can we get this training? We're going to create our own training programs. So now you have a conflict in the hospital because you have the interventional radiologist and you have the vascular surgeons being trained. Okay, well, if you're the patient, your doctor is going to send you to vascular surgery because that's the traditional place to go. And they're going to be doing this on you. They don't have the years of training historically from their field, but they realize the world is heading towards more minimally invasive. So we need to be boat drivers too. And I applaud that. I say it's good. Everybody needs to develop and, things that we did 10 years ago and 20 years ago. So the world has moved towards more minimally invasive. And what we debate all the time in our groups is if somebody's got a blockage that's this long in their thigh, should they have bypass first or should they have endovascular treatment first? And by endovascular, I mean minimally invasive. And you will see grown men go to blows on this on stages left and right. Yeah.
It's so bad.
Man. Because that's what I have.
It's
I have
brutal.
100% blockage in my SFA. with no
Right, and that's
bypass.
exactly the case. Me, I'm a minimally invasive person. I say 100% of the time, I need to be able to push a catheter against that and feel what kind of blockage is that, right? Always, and this is an endovascular first approach. I have partners in at my second location, 3 hours away, that will do the diagnostic angiogram all day long and say, oh, nope, this is a surgical. This is surgical. They're more old school. And I'm saying to them, come on, you got to get endovascular, do endovascular. And they say, no. The surgical works great. Surgical works great. Yeah, it's a bigger procedure. You seem healthy. You can make it through it. Let's do the surgical bypass. So what you don't realize is you're put in this like little blender. So IR, my field, we're image guided, catheter guided. All we have ever done in our whole lives is moved catheters through vessels. So wire selection, catheter selection, stent selection, devices, tools. I've got a lab right now that probably has 30 different of these things. And my job is to know all the advanced techniques and use all the advanced tools and be just a little better than everybody else at how to spin a wire, how to use, right? So I say that we're like plumbers. If it's open, and needs to be shut down, meaning you're bleeding, we can shut it down. If it's shut down and needs to be open, we open it up. We're just human plumbers. So fibroid embolization is, IR does like over 50 procedures, but it's all minimally invasive image guided, right? It's all boats. We drive 50 kind of boats, but we only drive boats. We don't scalpel. We just do anything that's image guided, and our expertise is in wires and catheter movement. Okay, so and patients will be really confused about that, like because I'm not a gynecologist, so I do a lot of fibroid embolization. I've saw 2 patients today, and patients will talk to me about the hormone replacement, and I'll say, no, I don't do that. I do tumors. So it's the uterus because it's a tumor. I do liver because it's a tumor. I do the kidney because it's a tumor. Does that make sense?
Okay, it does. But when it gets into things like CLI, like if you're spending, I don't know, a third of your day or however much you do on uterine, then how can a doctor really be good and know those small vessels in the foot?
I would say our lab has defined those small vessels. So I would say it's not hard. It just depends on what you're dedicated to doing, right?
Okay.
It's like saying you make biscuits. How could you be good at chocolate cake? Well, you just take the biscuit principles and you make them, and then you do that for a couple years and 5 years and 6 years, and you keep asking questions and you say, hey, this flour didn't rise. Why didn't it rise? Let's push that. Let's keep going. And then you say, wait a minute, on these fibroids, how come this isn't, and so if you pick your things, so for an example, I'm board certified to read any diagnostic imaging that any one of you have, chest x-rays, CTs, MRIs, knee MRIs. I don't do any of that. So I would say I've dropped off 91% of what I'm board certified to do. And I do 8% of what my license allows me to do.
To focus.
Yep. Yeah. So, so 2 things, not a big deal. 3, 4, 5. I could probably do 10 things really well. Once you get into, like, I don't read knee MRIs. I never would. If somebody, I would be like, nope. Could I? Yeah, I could. I technically can. Brain MRIs, I can read all those things. I don't do any of it. So I kind of flip your question on the other way, like, oh my God, if you saw the things I didn't do, so yeah, it's a very natural in our field. I do veins, arteries, I do some cancer stuff, not a lot of it. That's another example. I don't do a lot of liver metastatic treatment. I could easily do it, but I do think when you do something, you need to do it completely and well. Those are service lines. And I only do service lines. I only drive cars or only drive ships that I know that I'm going to do it completely to the end. I don't dabble in anything. But I don't think you can look at any one profession and say, oh, wait, that doesn't make sense, because the fields are so mixed these days. With minimally invasive and open surgeries and tools and techniques. And then you also say who has access to things, right? So if you're in more rural communities, these were family practice doctors who used to deliver babies and do C-sections and do appendectomies, right? So depending on your community and what kind of specialists you have around, you may have somebody who's a general surgeon who is really good at our arterial disease because
Right.
they're the game in town for the last 20 years.
Good
So
points.
take that versus you're in a major university and there's 40 people fighting for the same little pile of patients. And this happens a lot in big universities. A lot of big name people actually don't do a lot of the work, right? And their names associated with stuff, but they're not the ones actually pushing the catheters. So this happens a lot with the titles, heads of centers. Oh, he's the chief of whatever. But what they're doing is mostly admin. And I won't name names, but we see this. And I do a lot of conferences and talks, and I got to be a little careful what I say here, but a lot of times the big names, sometimes they are great people doing a lot of the great work, and then sometimes they really haven't had their hands on catheters in quite some time, that their residents and fellows are doing it. And so, it's very hard as a patient to know. I mean, you can have somebody with very minimal looking credentials who really have done advanced work and have a lot of respect in the field. And I would say talking to your people like Kim,
Right.
Because I've seen
thank
it.
you.
Oh boy, do I see it, and it drives me crazy. I mean, I've even been in labs where there's been an art major that is literally sitting there as the scrub tech doing the majority of the procedure, and the doctor walks in and says, "Oh, everyone see, I touched the patient. I touched the patient." And I'm like, I wouldn't want, and I mean, they might be now good, but I wouldn't want someone that doesn't have that board certification touching me. I mean, that is crazy. And I've been also on the phone with large facility doctors, big name doctors, who have been up on the phone with me and having people calling in the middle of our conversation. And I'm like, what's going on? Oh, I'm actually supervising a procedure downstairs. Wait, what? Does the patient even know that you're not in the room? That you're just doing it remotely? Are you kidding? So you just never know. And you do need to ask your doctor, who is actually doing the procedure? What is the skill set? If you're not doing it, even if are you in the room? Who's doing it? What is their skill set? How many times they've done it? What is their success rate? You need to ask those questions, and they're really, really important. And doctors, if they get upset with you for asking those questions, red flag, go somewhere else. But I would imagine most doctors are used to these types of questions, and you should feel comfortable asking them. Any other questions that we have in the live studio audience? I do have one from Joanna really quickly that came in online through our social media group. She says she has a question about total knee replacement and having PAD. She's curious if this is a bad idea due to the lack of blood circulation. Is it safe?
It would depend on what PAD meant. In general, so that would depend on the degree of the arthritis in the knee and the function of the patient. So if you're immobile from knee pain and you're really in a dire situation, then our goal is to keep you mobile. It doesn't help your health at all to be unable to walk. So if someone says, my knee hurts so badly I can't walk, I'm like, get that knee replaced, because you need to be mobile and walk and enjoy life. We're all here to enjoy life. But if you have, so 95%, yes, you should get that knee replaced. Hard to say specifically.
As far as precautions, though, making sure that you have both inflow and outflow, right? Beforehand, making sure getting a vascular assessment at least.
Yeah, I definitely think, and I feel like the orthopedic guys should, if there's any question, they should be, a lot of people have that diagnosis, but in fact, I would say anybody who's getting a knee replacement always has some degree of PAD. I kind of say anybody over 55 probably has some calcification somewhere. I mean, it's just age, it comes with age. So if they can feel the popliteal artery, so they should be doing an exam where they feel the popliteal artery behind the knee. If that's pulsatile, then you're probably okay, because it's not going to affect the small vessels down in your foot to have a knee replacement.
Yeah, we had one that it didn't heal. The incisions didn't heal because of lack of blood flow. And this person was very upset that they didn't do a proper vascular assessment prior to having it. But there's another option just to fire Marcia up a little bit more. for IRs that they're offering is genicular arterial embolization, which is at least something that could help delay a full knee replacement, right?
That's right. So geniculate artery embolization. So yeah, Marsha will say, what are you doing on knees? But again, it's just the artery to the knee. And
Marsha, we're picking on you.
The leg goes down, and then there's an artery called the geniculate artery. There's actually a bunch of them. And you go into the geniculate artery with your tiny little catheter, you inject, and you'll see the joint light up, and it's inflamed. And so you inject these little tiny little bit of particles. It cuts down the inflammation, and people have good results with it. Right now, it's been around for about 4 to 5 years. There's some really good literature. We're getting payers to start to be able to pay for it. So, it's not a complete replacement. I would say more important, especially for the guys, is prostate artery embolization. So just like we can go down into the uterus through the uterine artery, we can also, it's basically the same territory for the prostate. Why I love uterine artery embolization and prostate artery embolization, the alternatives are really big deals. So for the guys, the prostate alternatives are something called TURP, which has a lot of morbidity, impotence, and there's a lot of like surgical comorbidities that go with that. So instead of doing that, what they do is they go through the urethra and they like blast up the urethra. You go into the prostate, you could put in these little particles, and the prostate shrinks. So you don't, and it works really well to relieve urinary obstruction. That is a really good one for everybody on this, to just Google search. There's not very many people who are going to say they do it who don't actually do it. That is also an area where you really want to go to somebody who does a good job at this. I've got a partner in Eugene. I don't do it myself. I used to send people to Denver, but it's definitely one of those, it's like worth finding a good person and traveling for. So yeah, I know. I know. Sorry, Joshua. It's really, it hurts me, and I'm a girl, but it's why I like prostate artery embolization. This is why my field is so satisfying, is we can take these procedures that have so much comorbidity, and you look at the bypass graphs and the things that happen with bypass, and it's like almost a miracle some days. You just do these things and you're like, well, that was easy, and flow is restored, and you save a limb. Save a prostate.
I love Joshua, our producer. He picks out those perfect quotes. It's just he's really listening. I don't know your timing. I'm not sure. We still have a few more questions that I have for you, but I want to make sure to respect your time. And
okay. Or if Martha, I don't know if Martha's got another question.
I think Marsha might have another question. Go ahead.
You're muted, Marsha.
I lowered my hand. Back to the knees. So my knee is going, and I'm really, really active. But so I went to an orthopedic surgeon, and he took x-rays and stuff, and he's like, yeah, you're on your way. He gave me meloxicam. Well, it's great. I absolutely love it. But I already have some kidney, very mild kidney issues. So I know I can't be on it long term. And I'm just wondering, like, what kind of doctor would I go to for my knee if I'm not going to an orthopedic surgeon? I can't take meloxicam for very long. I've been on it, I think, almost 3 months. So would it be a radiologist? I'd want to go see a radiologist for my knee.
Yes. So believe it or not, because we have an identity crisis in our field. We are interventional radiologists. That term radiologist at the end really throws people. So focus on the interventional part. So you need an interventional person, right? And so there's a lot of things you can do with knees, stem cell, PRP. There's a lot of like injection type stuff that folks do. So I would find in your area, like a minimally invasive knee. I mean, it's kind of like everything else. There's all these things that you can do between nothing to knee replacement. And it's really going to depend on the degree of cartilage damage, where the next phase of this is going. There's a lot of people do stem cell regeneration. Now, a lot of times it's not covered by insurance, so then it becomes a cash pay. I mean, that can be a little complicated. But just like in backs, normally you're injecting backs a couple times before you go to back surgery, and the knees are there too. What they're going to do with knee replacement, it used to be when I was younger that knees and hips only lasted about 10 years. And so they tried to get you to be as old as possible before you replaced. Now those devices do last longer. So they're putting them in younger and younger people. So it's kind of like with minimally invasive stuff, you can do it safely earlier on. So finding that sweet spot for you. And I'm always like, try everything that's non-surgical. And then when it's not livable, then surgery. And I mean, the reality is it's so many people are doing knee and hip replacements. It's a lot safer, faster, easier, quicker, more successful than I would say was when I was in med school. But geniculate artery embolization, look for an interventional radiologist. Okay. And then, and it's called GAE. I know that word is a big word, but artery embolization. Embolization just means blocking off an artery. GAE.
Yeah. Okay. And Paula, did you have a question? You're leaning into okay. Go ahead and unmute. She's been trying to jump in here. Go ahead and unmute. Do you need some help here? There we go. It should pop up on your screen.
Yes.
There you go. Perfect.
I'm finding everything so interesting to listen to, but I do have a question. Actually, it's about my son who lost his big toe from that that infection. What is it called?
Osteomyelitis.
Yes, osteomyelitis infection. And it's healed fine. His feet are extremely dry, but he has swelling still in the foot and the leg. And I noticed that she had said something about using compression. They say that they've done a Doppler on him, and they say that his blood flow is fine. He is a diabetic, and he was a bad diabetic. He does have it under control now, but I'm not quite sure if we're in the right spot where we should be, or if we should be seeing this even more by going to have a vascular doctor or something, because they've told him that his blood flow's fine.
I think the same situation, right? As we were talking earlier.
Yeah,
Is his wound completely healed?
Yes, the wound is completely.
Okay.
Yes.
Well, I mean, first of all, congratulations to him for getting his diabetes under control. Many people don't, especially, I mean, I'm a mom of boys, 17 and 19. So I feel you on that one. Even a podiatrist who was diabetic since he was 15. And it wasn't until he had his 3 foot wounds and was told there was nothing to do. And we treated him and he healed, but that was his wake up call at 50, even a podiatrist who treated diabetic foot wounds. So it's real common. So congrats on getting that diabetes under control. It's like the single most important thing. Secondly, yes, you should be able to compress, and you do. So any swelling in the foot, it's like waterboarding a foot. And it's really important. It's something that's so, so simple, and something that people should be doing every single day who have edema. When you do a skin biopsy of any limb that has constant edema, you can see all the inflammation underneath. So you do a punch biopsy of a leg that has swelling. We know that it's a state of chronic inflammation. So anybody who has diabetes, already had osteomyelitis, you're already having risk factors. So you, in particular, want to get the skin care really good. So we're constantly talking to patients, especially our younger dudes, like, now's the time to start. I love Eucerin lotion. It's kind of expensive. It's like $30 for this thing.
It's good.
But it's really clean. It's really healing. It doesn't feel that greasy. And because those little skin nicks are where you get skin breaks, you get little infections, and we don't want that. We want intact skin with no edema. So should you see a vascular person? I think anybody with diabetes, yes. See a vascular person. Why not? This is going to be the best copay you've ever spent, is with the specific question of, can I use compression? In my lab, we would ultrasound the foot. My guess is, because there was healing of this, there would be class 1 flow to the foot. And we would tell your womb person, your patient, your son, yes, compress a lot. Okay. So one
a
the wound care
compression
people,
stocking.
yep. And the medical grade is 20 to 30 millimeters of mercury. Often, depending on your son, if people are overweight, they have arthritis, they can't get a sock on, sometimes they'll do the 15 millimeter of mercury. The reality is that whatever a patient can get on and be compliant with is going to be the best. So
Okay.
even though the 20s are the medical grade, lots of people want to start with the 15s. Rule of thumb, just wear it as much as possible. For the beginners, you can put it on at night. So you're laying on your bed. It doesn't feel so pinchy. The thigh high is the best kind, but very few people are going to put a thigh high on regularly. But as you can imagine, that pushes the fluid all the way up the leg. The knee highs sometimes pinch around the knee. It just depends on your son's leg shape.
Okay.
But
Well,
it's not an easy, I mean, sometimes it's trial and error. I always say go to like your local pharmacy or Walmart, Rite Aid, wherever. They always have that turnstile.
yes.
Like a sock. There's a diabetic sock right now. They're like $35. Best investment you can make ever.
Really?
So they don't want you to compress when you have, what will happen is, again, people get lazy and they're like, oh, don't compress, you have PAD. That's not true. That is not true.
I've been told that too. Not
Yeah,
to use that.
Yeah, that's not true. It's just too lazy. It's not enough attention. Like sometimes people really need compression. And we don't know. PAD is all sorts of things. Critical limb, that's that worst category. And just because you have a wound in osteomyelitis doesn't mean you have critical limb necessarily. So you need to go to his wound care or his vascular or primary and say, my specific question is, can he have compression? And then you say, we heard from a doctor that just because you have PAT doesn't mean you can't ever wear compression. What are you going to do about the swelling? And then ideally someone orders an ultrasound at least and says, yeah, the tibial vessels are open. This looks good.
So could he start wearing one tomorrow, or should he
I
go?
would. I mean, I would, but
That's what I'm wondering.
Yeah, I mean, I don't think there's any harm in starting a 15, and you just want to keep an eye on it. If you put on a 15 tomorrow and he says, oh my God, and all that, you look down and the foot looks like it's not getting any blood flow, take them off.
Okay.
But
Okay.
the chances of that are pretty unlikely.
What's bad about it all is he has schizophrenia. And so
yeah.
we're really dealing with also issues there too to help him.
Right. And so here's what happens with schizophrenics or people who have any sort of personality disorder or mental illness is that they sometimes don't feel things. So,
right, that's him.
Right. And so just, mom, just check every once in a while, that he allows you to, and so he's going to be unlikely. So maybe you want to just start, hey, we wear these at night. And then you take them off in the morning. Something's really like routinely algorithmic.
Slowly guide him into
it.
Yeah.
And I mean, at night, and I know night can look differently for people with schizophrenia, but, some pattern, or we wear these during breakfast, even if you get them on for 2 hours a day, we wear these when we watch our movies or whatever it is.
Okay.
That's going to be enough.
Okay. So a person with PAD can wear compression stockings?
Yeah, because a lot of people have mixed disease. So yeah, you can.
Yeah.
And that word compression means a lot of different things. So I know the message has been don't wear compression. What we don't want people to do is with really severe, like wounds and really severe disease, just to go throw on compression without having somebody understand what their vessels are.
I see.
Right? People with PAD have to be very, very careful with their feet. And so can you do it? Yeah, like it all just depends.
Okay.
Right? It's like saying, again, we go back to the cancer thing. Can you have cancer and have hair in your head? Yeah, you can. Lots of people have cancer and hair in their head, and lots of people lose their hair too. So it all depends. And that word, peripheral arterial disease, such a broad. So we don't do anybody a service by saying, everybody, here's what we do know. You shouldn't smoke. You should control your diabetes, and you should walk. Short of that, the answer is it all depends on you. Your vessels, your individual makeup.
Now, okay.
Yeah, we're always very careful. We find a lot of doctors just willy-nilly prescribe, oh, go wear compression socks, and they don't bother to actually sit and really evaluate the patient. So we usually are on the side of, hey, if you have PAD and you're in the group, and we tell people just in general, hey, don't do it. Just you need to talk to your doctor to make sure that you're properly evaluated, to ensure, as you were saying, check those tibial vessels. Also, let's get an ultrasound of those veins and see what's really going on there, because there might be something that you could super glue, or you could do a little zap of some of those valves to help bring some relief. I know that
The mixed
for
disease.
especially, right?
I have
Mhm.
one.
Especially for
I have one
CVI,
more question.
but
I have one more question. Is that okay?
okay.
It's I just had the procedure done, Kim, from my doctor that opened up the artery from my knee to my foot. It's all open now. But I have swelling, and he told me that I would have swelling. I have pitted edema in my foot. It's not bad, but it's there. Could I wear a compression stocking?
Don't do it. Don't
No.
want compression. Give it a couple weeks. It will slowly go away. Don't compress that.
Okay, that's what I was wondering. So, oh, okay, thank you.
See, it
Welcome.
depends on the person. I'm glad you asked. And
Yeah.
definitely something you should have a discussion with your doctor if that swelling doesn't go down and pain isn't relieved. So always get that checked out and stay in close contact with your doctor. And if I know your doctor, I will I can message as well
Yeah.
as Dr. Constantino knows.
It's fine.
That's
It's
great.
just, he told me I would have swelling,
Yeah.
and it would last 7 days or better. And today is 7 days. So, and it's better, but it's still a little bit there. The blood flow I can feel, I can see the difference. It's amazing.
That's great. You'll
He's
get there.
he's giving me my life back. And
It's interesting because some people actually feel instant relief, warmth of foot. Wow, look at
Yes.
me dancing. And then other people, like I'm sitting here, I'm on text right now with someone else who's saying, "Hey, it's been a week since my procedure and my foot is on fire." It's like, and then there's you that you're saying, "Hey, I'm a week out and I have swelling and I have a little bit of pain." Like, is there any normality to what people experience, Dr. Constantino, after one of these interventions?
No, and it's really different. And feet, no, there's not. And so what we look at is, as long as you're not feeling something that makes us worry that there's a complication. And I liken this to, like, if you fall asleep on your arm and when your arm wakes up, it can hurt worse, you know? So it's all really different because it depends on what kind of nervous innervation you have of your foot. So we like pain because pain means your nerves are alive and your foot's alive. So
Makes sense.
in a weird little sick way, we're like, pain is good. It means you're going to feel things. This is good. The non-feeling foot, that stresses us out because now you have a foot where you don't feel. And so things can happen to it. You won't know.
Okay.
Okay, our final few questions here. I know I promised you we were going to be done. I have, but I want to get these in because these are part of a grander series and they air on our radio show, The Heart of Innovation, which we do every week as well. So I want to make sure to get you in here. The Journey to Diagnosis is our first series that we have. It's share a case of a patient that should have been diagnosed sooner, and their story is representative of what's happening in the grander world that needs to be fixed.
One of our favorite clinic patients is, we call her JJ for initials. She was she made lunch at a middle school and she had stood on the concrete floors, and she thought she was going to have, she said, I don't think I can work that much longer. She was young. She was maybe, I don't think she was quite 60. And she thought the floors were just killing her feet, but it turned out she had femoral artery occlusion, and she had seen multiple people. She had gone to the doctor, and she had a hard life. I mean, she had a daughter that she was trying to take care of, and she was living off her income from the public school, and she didn't know what she was going to do, but she just had so much foot pain from standing. And what happens is people say, oh, it's just the hard floors. But if you're having trouble standing on a hard floor, whether it be a concrete cafeteria or we get a lot of patients who work in like machinery on like manufacturing.
Assembly line?
Yeah, assembly lines and standing, and they feel like the floors are too hard, but it's just their arterial disease. So I would say that's one to look for. And it shouldn't hurt to stand on concrete.
And tell us about a case that still sticks in your mind today over how many years that you've been doing this?
Gosh, a lot. God, so many. I mean, the case, well, I'll tell you, yeah. I mean,
A case that you learned the most from.
oh God, okay. Well, for me, early on, I had one where I went, she came to me for a wound, and then she had a blockage in her thigh artery, which is her femoral artery. And I opened it up and her wound healed. She had rest pain on the other side, but no wound. Same femoral artery blockage. I opened that one up, but I went subintimal, meaning into the wall. So when you go down the artery, it's like going down a pipe, and you can get into the wall, go down, and go back in. That's called subintimal. We talk about it all the time. Patients would never know that somebody went subintimal, but that's what that word is, subintimal. So intima is the lining. Sub means you're going down the wall, inside the wall, and then back in. And there's things called re-entry devices where you go in subintimal and you say, okay, I got to go back in the artery. So you turn the re-entry device and you pop through. It's all sorts of tips and tricks you can do. I went subintimal and the pathway didn't stay open. I stented it, and she ended up having a bad outcome and had an amputation. It's the only, to my knowledge, and I feel like I would know, amputation complication of an arterial thing that I did, which, I mean, I went to the hospital, I cried. The family had to console me. I mean, I felt terrible. And the reality was that she was like, look, everybody in my family's been amputated, and you did the best you can, but that wasn't good enough for me. Those cases, this was years ago. And I mean, oh my God, I wanted, and to this day, I hate subintimal. I will pull back and go again. And so I think we remember the cases of the things that we're technically kind of allowed to do, that people do, that have a bad outcome. Nobody who does complex surgeries or any procedure is going to be 100%. But I think that those ones where we lose really, really weigh on us. Alternatively, I had a guy who had gangrene on all of his toes and horrible rest pain and horrible edema. And I mean, I never saw this man speak for over a year because he had so much pain. And we slowly managed to get him out of pain, get his edema compressed, he actually had transmetatarsal amputations bilaterally. He was told palliative care, bilateral amputation, and nothing more to do. And I really credit his family, his daughter, and his wife for just all the doctor's appointments and showing up and doing all the things. And here he is a year later. He has both of his legs. His gangrene is gone. He basically had mummified toes. So he had, and so that's more of just sort of an example of if you have like a dedicated team, you can get there. Keep putting in the work. And I feel you feel bad when patients have to come back, but he landed on my door with so much bad disease. So I think, again, that teamwork, and just two steps forward, two steps forward, two steps forward, you're going to occasionally have a step back, keep on going, and you want somebody to be your partner in that.
Yeah. And that's both on the physician side as well as the patient side. The patients need to be an equal partner and they need to show up. We have a patient that is on deck for bilateral AKAs, and I have felt like I am working so much harder than that person in fighting, getting the doctor on board, the doctor's office, calling the person, and the person leaving the phone at home or not answering the phone because they don't recognize the number. It's how bad do you want to save your leg? And I can't work harder than you do at saving your leg because it's just not going to end up in the way that you want. You need to have an equal partnership.
Some people don't want their leg to be saved. Some people are like, I don't care. And that's okay too. That's okay. But it's what you say. I can't work harder than you do at this, and it is, these are complicated procedures, even though they're minimally invasive. And I try to reassure my patients, don't worry, like this is going to be okay. You're going to be okay. Really, from the operator standpoint, we think about these are not easy things we do. they are hard. And if Kim's my patient, you and I are entering this, and I will fight for you like I'd fight for my own mother, sister, son, child. But you have to want this also. And not every patient does. And that is okay. And all I can do is offer you, tell you, be here, and also have an office that cares about you and makes you feel cared for. But if you and some people will say, I wish I had this amputation earlier. I went through this surgery, this, and this, and it was such a hassle. I wish I just and that's okay. But that's not going to be my patient because I don't do the amputation. So,
So 6 minutes that matter in your career, that defining moment in your career.
God, so many of them. I mean, I can tell you that I'll talk about a personal story of my brother-in-law. My sister is adopted out of a foster care system. She's got some developmental delay, and she married a man who had some congenital abnormalities and diabetes, and he was older than she. And while I was in the vascular space here in Oregon, he's diabetic, and he was at Kaiser, Northern California, and was admitted with a diabetic foot wound, which then got infected. He never made it out of the nursing home. So 3.5 years later. And so it's a little strange because I work in this world, yet this is happening to my family member. And I'm assuming everybody's getting the level of care that I give, right? Kimberly knows this story. And this is how I learned this lesson before I met you, when really I thought like everybody's doing this kind of stuff. And it wasn't until, and the other thing is, he was my brother-in-law, so he has his own family taking care of him. And my sister's not a reliable historian. So he ended up having a toe amputation. I would say the podiatrist was really the only person taking really great care of him. And his hands were tied and what he could do. He ended up with 3 surgeries. In the rehabilitation, he got so debilitated from his physical therapy benefits ran out. And then he got depressed. And so he never really would get out of bed. And then, COVID happened, and probably in the 3rd round of COVID, he got it, and then he died 2 days later. So that man's last 3.5 years of his life were spent because of a diabetic foot wound. Being decompensated until, and this was a terrible place to live. It was one of those 2-room nursing homes that every single person says, no way in the world. I do not want to go there for the rest of my life. And that's what happened to a family member of mine. When, the device reps know the IRs down in Kaiser. And so I called and had the conversation, and there was an angio and really nothing to do. And so my hands were a little bit tied because he was a Kaiser patient. I have a family member who doesn't really understand. I'm dealing with a brother-in-law. So, and, I'm on the phone talking to him saying, do this, do this, do this. But unless somebody's at the other end who can actually do this stuff, and you have to have a motivated patient, right? So why wouldn't he just get in an airplane and come up to me? I can't go to Kaiser and push catheters through people. I'm not licensed in California. So, this really showed me that the decline that people have with something as small as a little wound, a little cut, a little wound, what that turns into. And it's why when someone comes in and they've got a little wound and they've got class 4 flow, we are all hands on deck. And I like to get those people in 48 hours because I've seen personally what this turns into. So, and I walk into a room and I look at those, I will rip off peaceful socks and look at their feet because I want to know what these feet look like in front of me and how do I triage you? And the big, bloody, horrible gangrene messes, we all know what to do with those. The little wounds that are like the ticking time bombs, those are the ones that I don't love when patients are out there, the ticking time bomb thing, because I want to make sure they get the attention they need. Anyway.
You have such an amazing heart. I just absolutely adore you. I appreciate you so much for all you do to exhaust all efforts and truly advocate for not only your patients, but you're always out there advocating for everyone, every patient across the globe. And we love you.
You're amazing. you have done, Kim, you deserve a Nobel Peace Prize. I mean, you're the first person to bring this, and you have given us the ability, without you, I'm just talking to myself in my office, so it's the work you're doing truly. And everybody on this should know how much, how well respected she is in all of our communities. And really nobody took this ball and ran with it until Kim came along, and it's not easy. She's fighting an uphill battle against a lot of like old institutional thought patterns, and pioneers take the most arrows, and Kim was out there doing this and is truly saving limbs. So I think that I would say to everybody in my field, Kim, is that we really appreciate you approaching this from a patient first perspective that puts us into touch with patients who need us. So anyway, thank you. I mean, you're really a superstar who is changing all of this. We're just, like I said, pushing catheters, but you're getting this out to the patients who need to hear this. So thank you.
Thank you.